So I thought I would give a talk and a little bit about an academic journey and path and the people who influenced it and changed it. And I think sometimes when people say, oh, well, you're running this clinical trial, that's great. And how you may get there and some of the paths of how to get there, so that if you're interested in doing it, that it may shed some light on the process. And so I thought that the one thing that there's no question who you are in the world, there's one thing that is absolutely constant. We all have the same amount of time every week. And the big question is how are you going to distribute your time to be able to get to where you'd like to go? And I'm going to tell you about all the things that I did where I really distributed my time very poorly, and would do it differently along the way. And so for Dr. Norton, I put up there where I went to high school. And for those of you who've ever lived in St. Louis, that is the first question people ask you is where you went to high school. So I thought I'd put it up there. But I went to Penn undergrad and then went to WashU. And I went to WashU as a medical student. And my father was a medical oncologist, so I was sure I was going to be a medical oncologist. He was a mentor to me my entire career and had really left clinical medicine after leaving Italy and dedicated his life to immunology and immunologic research. And so he was one of the early B-cell antibody researchers in the 1970s. And so I thought that I would very much follow in his footsteps, that practice clinical medicine, but also have a translational research lab. And I was certain that in surgery that would never, ever happen. And I did my surgery rotation last in my third year. And this is when it was more traditional in terms of the blocks that you had as a third year medical student. And the first 2 years were in the classroom. And I had the great fortune to be on this service. And so you can see the types of mentors that I had the huge privilege of being on service with and from learning. And Dr. Wells, as the chair of surgery, was a surgeon scientist, as were many of the colleagues that he had recruited to the institution. And for me, it was absolutely transformative. And Dr. Norton was assigned to our small group. So all the medical students that were doing the surgical clerkship were divided into groups of 5. And I was part of Dr. Norton's group of 5. And it was learning from Dr. Norton and learning about how to ask questions, about how to really take those clinical questions and go one step further, go to the lab, think about them, think about clinical trials. I mean, it was truly those small group sessions and the time in the operating room that was absolutely transformative. Many of the surgeons, Dr. Moley, Dr. Doherty, Dr. Wells, they spend most of their time doing thyroid and parathyroid surgery. And I thought thyroid, parathyroid was interesting, but kind of I didn't really like the neck that much. And so it was really Jeff Drebin and Jeff Norton who exposed me to pancreatic surgery and the love of the pancreas. The senior resident was John Olson, who many of you recognize, and then the junior resident was Chuck Vollmer on service. So a very pancreas endocrine heavy service. I also want to mention that with the number of MEN patients we saw in those clinics, you could actually think there were that many MEN patients in the world to justify all the questions on the in-service about MEN. So I have to say it was also the ability to see how the research had helped develop a clinical niche practice that then drew the patients from all over the country and the world to come see these surgeons, and surgeons who came to visit to watch them operate. And so I actually then ended up going to Boston. And the main reason was that my mother, who was still in New York, begged me to please come back. And we didn't have any family in the United States. It was just our nuclear family, my brother and I and my parents. And so I ended up going back to Boston rather than staying at WashU. And I had the great fortune there to have wonderful mentors as well, and to continue on in that pancreatic cancer and pancreatic pathology legacy. I was the last class admitted by Jerry Austin, and many of you know in the audience, Jerry Austin was the chair of surgery at MGH for about 40 years. And it was just as he sort of passed it over to Andy Warshaw, and that made the department even more cancer focused and more pancreatic cancer focused. And Charlie Ferguson was our program director, who I love dearly as a real great mentor and teacher. So it was time for me to do my academic time, and I was very excited. I was going to go to Sloan Kettering, and I'd grown up in Westchester County, New York, so I was going back to New York City. I was going to see my high school friends. This was going to be great. I was going to have this research position with Johnny Lewis, and we're going to be studying immunology and immunology of sarcoma. And I'm very happy to see on the whiteboard you guys have a nice immunology lesson. I thought maybe you guys planted that for me. But I arrived, and it was the first week of July, and I'm really excited. And Johnny Lewis goes, "Oh, Cristina, it's so great to have you here. I just want you to know I'm leaving Friday." And I said, "Leaving?" And he's like, "Yeah, I'm going to industry." And so he left, and I was sort of thought the entire world was kind of crumbling down. And it was really thanks to Dan Coit, who took me under his wing, and I pivoted a bit and did a lot of melanoma immunology research. And when you think back, this is in 2000, 2002, when you think about immunology research at that time, there were really only a few diseases studied immunologically. It was melanoma and renal cell carcinoma, right? Because we really didn't have very much, and we didn't understand the immune system to the degree that we understand it now. We didn't understand the immune modulation that we could use. And this was sort of the first time that I got to see a young faculty really struggle. So Ron DiMatteo had finished his fellowship and was a brand new faculty. I was in Alan Houghton's lab, which was a big internal medicine immunology lab based on melanoma. And Ron was setting up his lab. And it was absolutely fascinating to see how many barriers were put up to him getting his lab set up. People didn't want to mentor him. They didn't want to have him part of the lab meeting. They weren't willing to share equipment. And it was a real eye-opening experience about the environment that you're in. Mike D'Angelico was the clinical fellow at the time, and I did a few research projects with him because he needed a gopher basically to help get the clinical data out and be able to write some of the papers that you need to write as a fellow. But it was a real educational experience about how your environment can change very quickly, but in the end actually may end up being a lot better. I had the great fortune to then go back as a clinical fellow, and it was a very interesting time politically at the institution. It was our class was the last class to operate with Leslie Bloomgart, and it was the year that Murray Brennan stepped down from being chief of surgery. So there was a lot of political turmoil, and it was interesting to see from the perspective of a fellow. Right. And I'm sure all of you have heard the line, "An institution will never love you back." And there is some truth to that. Right. And realizing what your role is in an institution and where you want to go and the environment that you're in. And waiting because you think you know you're going to get something is probably not the best strategy along the way. But it was a very, very interesting time at Sloan Kettering. One of the best parts of Sloan Kettering was that Murray Brennan had set up databases like no other institution had. And we were able to do a really great BRCA project. And the reason it was important was because, one, it was interesting from a data standpoint and being able to find this mutation in a subset population. But actually, the most important part was that Eileen O'Reilly was a brand new medical oncology faculty at the time. And she was very interested in this because the PARP inhibitors had just come out. And it was a great opportunity to transition all the databases that I had done and all the blinding I had done to be able to do all this genomic testing over to her to be able to give her the data that we had worked so hard to put together. And being able to transfer that to someone else is so important. I think sometimes when people leave institutions, they say, well, I built it and I own it. Well, actually, none of us own it. It's really the patients who own it. And we owe it to our patients to really pass things along so that we can make more progress in these diseases. And so when I was a fellow, I'd say the best part of fellowship, it's when I was a lot younger, is I met my husband, who was had trained at Mayo Clinic in orthopedic surgery and was an orthopedic oncology fellow. And so he and I needed to go find a job. I wanted an HPV job, and he wanted a spine tumor job. So you can imagine there's a lot of those jobs around the country. But we were very fortunate, and we ended up going back to MGH, and we both ended up working at MGH. But it was here that I probably made one of the biggest mistakes that I made, and that was I chose a lab at the Dana-Farber. The Dana-Farber is 3 miles away from Mass General. It is 3 miles away in Boston from the Mass General. And Murray Brennan said to me, this is the worst idea you could possibly have, Cristina. And I said, yeah, but I'm going to go work with Glenn Dranoff, like the immunology guru, right? Like now he runs, immunology for BMS. I mean, he was the person to work with, and his lab was huge, and this was going to be the greatest thing, and it was going to be so fantastic. Well, let me tell you, it wasn't so fantastic. Glenn is fantastic as a human being, but I was one of 30 people in the lab, i.e., who knows if I'm there or not there or whatever. And it was too far away to be able to really do research, right? You need to have that lab close to where you're practicing clinical medicine. And if it's not, you better be in a place where you can commute very quickly because there's zero traffic. Monica Bertinoli was an enormous mentor, even though she was at the Brigham. Now, of course, it's Mass General Brigham, so they're married. But in 2006, they were very separate, and they really didn't like each other as institutions. And Monica and Pat Donahoe in 2006 were the only 2 full professors who were women in the Harvard system in surgery. So there were really only 2. And she was a phenomenal mentor along that path and helped sort of reorient me a bit as I pivoted to make different decisions. So on the personal life front, Joe and I got married, and we had 3 kids fairly quickly. I was 36, 38, and 40. And it was definitely a hard balance. And so what I would do is in the morning, I would run to the Dana-Farber at 5 in the morning. I would set up my experiments. I would then run back, and then I would go and do my clinical stuff. The good thing is I didn't have any OR block time, so I tended to start most of my cases after 3 o'clock. So that was actually pretty helpful for my lab career. It wasn't so helpful for my, health or other aspects of my life. But the good thing about not having OR block time and always operating at night was that I got the same team, right? Because it was the night team. And so I got the same team every time I operated, which was really nice. And the way that the Mass General worked when I first started was the compensation was based on reimbursement. And so that very much influenced the kind of patients you got to take care of. And for me, that was actually great because I love taking care of the unhoused and the underserved populations. But most of them, have Mass Health or Medicaid, and you got to operate a lot more to make a living to be able to live in Boston. I had to do a lot of outreach, right? The patients didn't sort of just appear and say, oh yeah, I want an operation. So I think I went to hundreds of rubber chicken dinners all over New Hampshire, Vermont, upstate New York, Connecticut, Rhode Island, to be able to do that. Dr. Warshaw had asked me to become the associate program director to help Charlie Ferguson when I walked in back in the door in 2006. And so it was a huge honor. It was a huge honor until 2008 when they put us on probation because we were, not even close to the 80-hour work week. It was sort of one of those things where like 80 hours, what's that? Like that doesn't apply to us. Well, it did apply to us. And so we were on probation and we had to revamp the entire residency program to be able to get off of probation, which was a ton of work. And Charlie Ferguson took a lot of the brunt of that, which was not very pleasant to watch. I had been offered the program director job at that time, and I turned it down and stayed as APD because I got to do the things that I really enjoyed. And I wanted to keep my lab, the hope of a lab going, even though at the Dana-Farber, it really wasn't working. I wasn't getting grants, and the whole thing was sort of crumbling down as I was trying to do this. And I really questioned whether the lab was really in my future in any way, shape, or form, just because I couldn't get it off the ground. And I said, well, if I can't get it off the ground with a Glenn Dranoff as my mentor, then clearly this is just not meant to be. And I had the very good fortune that while I really wanted to only work on pancreas cancer, turns out a lot of people wanted to work on pancreas cancer, and there really wasn't a lot of air in the room. There wasn't a lot of oxygen for pancreas cancer, and they really didn't want Cristina also to be working on pancreas cancer. And I met these three young investigators who, very much like me, had about $5 in their pocket, right? We all struggled to get grants. We really weren't getting funding, and it was a real big struggle. And David Ting was a medical oncologist, Vikram Deshpande was a pathologist, and Nabil Bardisi was a PhD. And we'd all sort of been sidelined out of pancreas cancer. And we said, well, what could we work on that nobody cares about? And we came up with cholangio. We're like, nobody cares about cholangiocarcinoma. This is like, 2008, 9. I'm like, nobody cares about this at all. And I was like, great, I get operate on the liver, I get operate on the pancreas. What more do I want in life, right? And so we really worked together at figuring out what some of the challenges were in this disease. And with the four of us working together and all of us being at the same stage in our career, we all had skin in the game. And we worked together for almost 20 years, and we still continue to work together, even though now we're a little bit more split up, because we all looked at this as a group effort. And we did change the authorship on papers, some of it based on, who really needed this paper right now, right? Who needed this for their promotion? Who needed this for a different part of their career? And so we worked together to also make the first cholangiocarcinoma cell lines, because there were no cell lines. But the only reason that we could make this mouse model and make these cell lines was because I could take it out of the body warm. Vikram was the pathologist, so we got a huge piece for biobanking, and we could take it in the operating room because he would come, so there wasn't a margin issue, and we could put it in the different media, and we could basically figure out how we were going to have to work to be able to get these cell lines. And we were really lucky because we were able to make over 50 cell lines with IDH1 mutations, with FGFR2 mutations, so that we could do all of this modeling. But it only worked because all of us were in very different areas. I got to study my immune microenvironment. And so we all got something out of that puzzle. And I think it's important to remember, while Glenn Dranoff was the shiny penny, in the end, it was a much better effort to work with people who were at the same bandwidth as I was, where everyone needed each other, right? We all needed each other's funds. We all needed to work together to be able to get the projects done. We all needed to bring something different to the table to be able to do that. In 2011, Keith Littlemo came as chair. And of course, when we knew that Warshaw was stepping down, everybody started getting nervous. I said, what's going to happen to cancer? What's going to happen to HPV? And so we were very, very lucky that Keith Littlemo came. And will be forever grateful that Keith Littlemo recruited my dad to come with his NIH R01 funded lab. My dad had been chair at multiple locations around the country for microbiology and immunology, but then brought him from the University of Pittsburgh to be at MGH, which was the biggest gift that anybody could have given me, because I got to work with my father on the lab front while continuing to work with David, Vikram, and Nabil. And so we were able at that point to sort of pivot a little bit more to working on pancreas cancer, in addition to the cholangiocarcinoma work that we were doing, and translate some of the techniques that we had worked on to be able to go to that next step. And as Dr. Pousidas mentioned in his very kind and generous introduction, it was this idea of, when we're treating these patients, what is our goal, right? And for all cancer surgery, we really need to figure out, are we offering a potential cure? Are we going to help them live longer even if we don't cure them? Or are we going to make them feel better? And so this was the first case we did. And, it was a very young woman. She had little kids. Her life wasn't too different from mine. And she comes in with this scan with tumor clearly around her SMA. Her CA19-9 was 985. And, we talked about her in our multidisciplinary conference. And we had a little bit of insider baseball, in the sense that Dave Ryan, who was a young medical oncologist, was on the ASCO abstract review committee, and so already had a glimpse of what FOLFIRINOX might be able to do in the metastatic setting. And the CA19-9 of 985, I think most of us can probably agree that there's probably a good chance there's micrometastatic disease. And so she ended up getting 4 months of FOLFIRINOX. And you have to remember, when FOLFIRINOX first came out, the toxicity was brutal. The patients were so beat up because the side effects couldn't be managed very well. And we gave it, and her CA19-9 was just dropping, which was very encouraging. And then we gave her 50.4 gray of radiation, because we figured, well, now you got 12 weeks of no systemic therapy. If something's going to happen, it should probably happen in those 12 weeks. And I will tell you, we had a very heated debate in the multidisciplinary conference. You may have been able to hear it in Palo Alto. MGH is well known for a very high decibel level in discussions. And it was really about, what are the ethics around taking someone like this to the operating room? And can you really justify exploring someone when the imaging clearly tells you that is not true? So we were very lucky. We were able to get it out. We sent about, I think, 30 frozen sections, and, started from the left rather than from the right to be able to skeletonize the SMA. And this is what her path ended up looking like. She ended up living about 5 years. She did have intractable diarrhea, which was really debilitating for her life, but she did get another 5 years. But a lot of that ethical conversation did center around some of the work that Andy Warshaw had done since the 1970s. And that was the role of intraoperative radiation therapy. And he had this data that even for patients who were never resected, i.e. their tumor just stayed in place, you've given 50.4 gray of radiation, and then you give an extra boost of radiation, that 3% will have a 5-year survival. And so we basically leaned on this historic data to say, we can go to the OR and we can try to get it out. And if those biopsies along the SMA are positive, stop. Hard stop, no more, get out, because you're going to leave tumor behind. And that then, when we did our series, this is the paper that led to that. But what I learned from Dr. Norton was, you've got to study it in the patient, in the lab, and then you got to do the clinical trial. And so we set up these phase 2 clinical trials. And it was really so that we would be able to better track what we were doing, right? Because as soon as the patient's on the clinical trial, you have many more touch points with the patient, and all of the imaging and blood work is done at a very concrete cadence. And that's really important, especially when you're looking at different endpoints like progression-free survival, right? Because if you don't get a scan for 6 months and the other patient's getting a scan every 2 months, you're going to see progression earlier in that patient is getting scans every 2 months. And you can see that the two trials were set up very similarly. One was in 2011 and one was in 2013. And we used losartan in the 2013. And the reason that I want to highlight this trial to the students and the residents is because Hao Lu was an MD from China. He came to do his PhD in Rakesh Jain's lab. And he was working on breast cancer. And he knew he wanted to become a surgeon. And so he had reached out to me and he said, is it okay if I come to your Tuesday clinic? And I said, yeah, of course, come to Tuesday clinic and you can shadow and, hopefully learn something. And he said, you said that in conference, they said that the tumor is really fibrotic. And we're studying fibrosis in breast cancer. And losartan inhibits collagen-1 production. Can I look at your database? Sure, go ahead. So he comes into my office, and I keep this really ugly graph because he comes into my office and he says, look at this. The patients that are on an ACE or an ARB inhibitor for their hypertension actually might do better, right? And so it's just so important that, you as students and residents, sometimes you see a lot more than we see. It's like sometimes when you go walking with a young child, if any of you have young children, they oftentimes see a lot more than we see as we're walking down the path. And so, I just encourage you to speak up. And it really changed how we designed the locally advanced trial, because we said if of all places, this might be the place that it might work. And many of you have seen this data, so I don't want to harbor it. But it was very important because it allowed us to let people know that we're going to be able to downstage about 70% of people. And we ended up with survivals that we had not seen in pancreatic cancer before, right? An overall survival of 64 months. Like, that was unheard of. And in the locally advanced setting, we again saw very similar downstaging and tripling, almost quadrupling the overall survival that we had seen in locally advanced disease in the past. So we were very excited, and I probably was the number one soapbox. Neoadjuvant therapy is the winner and the key to everything. And it really took us a minute to be able to then go back and look at our data, right? So even when you get to your primary and secondary endpoints, you need to relook at the data from the clinical trial. And so this is like the sinker, right? And so after all that, and even though you were living longer than you were before, 80% of the patients are recurring distantly as their first site of recurrence, right? Which is exactly what we saw in the pre-FOLFIRINOX era. So we weren't changing the trajectory of the disease. We were just pushing the survival curve to the right. I'm not saying it's bad to push the survival curve to the right, because you want it to be as far right as possible, but it made us really think about, we have a lot more work to do in this disease. As someone who really thinks a lot about the immune microenvironment, we did this study and saw that changes in the immune microenvironment in patients who got treatment, one treatment changed the microenvironment, but also certain signatures allowed you to live longer. And that's what was the baseline to be able to look at this trial that we did in locally advanced disease that was funded by Stand Up to Cancer, and adding anti-PD-1 or nivolumab to the FOLFIRINOX and adding it to the radiation. And here you can see the ACE-ARB, the losartan, once again, as we were trying to explore this. And if we could break down the fibrosis in the tumor, does that allow the chemo to enter the tumor better, kill more tumor cells, and hopefully make the patients live longer? Unfortunately, the trial was negative because our primary endpoint was R0 resection, and we did not meet that primary endpoint. The good thing is that there's a lot of correlative science happening right now from all of these patients who entrusted us to be able to treat them. And so this was definitely very discouraging because we thought we really were onto something. And what was even more discouraging was the work that we were doing with David and Vikram and Nabil in pancreas cancer. And like I said, FOLFIRINOX, I was like, this is the be all, end all. Everybody should get neoadjuvant therapy because why would you not do that? And it was really this lab work that really changed my opinion and my stance. And it turns out that in all of the modeling we did is that the chemo actually changes the phenotype of cells. And that was really different, right? In the past, we knew that all cancers are heterogeneous. And the thought was, well, chemotherapy kills this population of cells, but it may not call this population this cancer stem cell or, the pluripotent cells, and, gotten all the different kinds of names. And that's exactly why patients metastasize. Well, it turns out actually that the chemo puts pressure on the cells and they change their phenotype. And the reason that this is really important is because we know that the epithelial phenotype tends to be the one that is more local. The mesenchymal or basal phenotype is the one that tends to be more metastatic. And so we're looking at this, and guess what FOLFIRINOX says? It makes you shift from an epithelial to a mesenchymal phenotype. And now we're all standing there going, oh my gosh, what have we done, right? What have we done in pushing all of this? And MGH was very much a FOLFIRINOX neoadjuvant, resectable, borderline, locally advanced, you name it, you walk in the door, you're getting it. And for the resectable disease, it becomes a really big ethical question, right? Do we really understand what we're doing? And are we going to miss our window? And even if we get it out, have we pushed the phenotype to a mesenchymal phenotype and pushed it to metastasize more aggressively than would have had we just taken it out and then given adjuvant chemotherapy? And so that was really the nidus to set up this clinical trial, which is the Alliance 21806 trial. And I thank the Stanford group for enrolling many patients and supporting the trial. I'm very, very appreciative of that. But it was to answer this question. And it was this question of, are we really going to impact overall survival if we give neoadjuvant treatment? So the standard of care is an operation and then 12 cycles of FOLFIRINOX. And we're comparing it to 8 cycles of FOLFIRINOX operation followed by 4 cycles of adjuvant FOLFIRINOX. And the reason a lot of people have asked, well, why didn't you just do 12 cycles neoadjuvantly? And so there were 2 reasons. When we originally wrote the trial, the adjuvant PRODIGE trial was not out. So 6 months of FOLFIRINOX adjuvantly was not yet the standard of care. But the other part was because of the phase 2 trials that we did at MGH, we knew that if you gave 8 cycles of FOLFIRINOX, you are not going to increase your operative complication rate. And that was the key, right? Because if you give neoadjuvant therapy and beat them up so much that you have a bunch of complications or they never get to the OR, then you've really done them a disservice. So we knew that the 8 cycles were going to be safe. So I have to credit Monica Bertinoli, who was the head of Alliance and then the president of ASCO, for being a huge champion and advocate and helping me get this trial, as was Eileen O'Reilly. And you can see the same people sort of come into your life at different stages and have really been enormous influences and help in my career. We are 96% accrued. We are almost there. And hopefully, with all of the endpoints and correlative science, we'll really learn a lot about this trial. The other part of this trial was we wanted the Canadians to join us. And so we gave the Canadian cooperative groups the leadership in the correlative science. So all of these tumors are being banked, right? And there's central radiologic review. And they are the ones who are going to lead the review of the grants. for the correlative science, because we needed to give them skin in the game to be able to advocate for this trial, to be able to open it in Canada. And it's been a huge help to have it open in Canada, not only from a diversity of patient population, but also from an accrual rate. And so I did want to put this slide in here because Matt Katz's Borderline Pancreas Cancer Alliance trial, which had to close early, unfortunately, did teach us a lot. And for the surgeons in the room, which I think almost everyone is, except for maybe the students, it is really important that if you have a neoadjuvant trial, it has to be surgeon-led. Patients come into your office, they want an operation, right? And it's only the surgeon that can really explain the reason to enter into a trial. You absolutely need to have central radiologic review, because you do get about 20% screen failures. So you don't want to find that out afterwards. You need a confirmed histologic diagnosis. And this has been a bit of a hurdle, and we've lost some patients because people will write suspicious for adenocarcinoma. And the reason that we were so hard and fast was because in Matt Katz's trial, he had about I think 10 or 12% complete response rate, which was much, much higher than we've ever seen. And so then it came back to, a bunch of those patients were suspicious. So maybe they never had adenocarcinoma. And therefore, they really are not contributing meaningfully to the trial. And maybe they were also treated inappropriately. We made the trial that you can give the chemotherapy locally, because think about the patient's trajectory and journey, right? They're happy to drive to Palo Alto to have their operation. They don't want to come to Palo Alto every 2 weeks. And what happens when they're nauseated, when they're dehydrated? You want them driving all the way to Palo Alto from 3 hours away? It's just not realistic. And so it's really important that the patients can get their chemotherapy locally so that you can help get that enrollment going. And you're thinking about the quality of life of that family member, of that patient and their family members, right? Because usually it's a family member that is taking the day off of work, driving them to chemo, picking them up, etc. And then share something to increase your enrollment. So, the question is now, what are some of the next generation of treatments? And the group here, led by Dr. Norton and Cedars and Visser, have written so much about this. So it's really bringing coals to Newcastle. But I do think that we need to be careful and thoughtful about how we bring in some of the new ways of treating the disease. I am very hopeful that improved local control in the setting of improved systemic control will have a significant impact. But remember, 80% of patients recur distally as their first site of recurrence, right? So the horse is out of the barn before we're even there. And so when we're talking about these extensive vascular resections, Dr. Cedars wrote a really nice paper about this, with a celiac resection. If you choose the patients correctly, your complication rate doesn't increase, and they have an equivalent overall survival to those who don't have a big vascular resection. So that is the right population to be more aggressive. But we need to make sure that we're choosing wisely and not just taking all comers. Ablative radiation, Chris Crane at Sloan Kettering has really pushed ablative radiation, and Alice Way has been the surgeon that has really been leading that. And whether or not that is going to be an option for long-term improvement in long-term survival, we have yet to see. Histosonics, they will be opening a clinical trial for locally advanced pancreas cancer. Excuse me. I'm hoping that the side effects are not the same side effects that we saw in IRE, because I think most institutions were very enthusiastic about IRE, and I think most have closed down their program and aren't doing it anymore. And then what about the new generation of systemic treatments, right? The new KRAS inhibitors. And about 2 years ago, excuse me, the first KRAS inhibitor was looked at in pancreas cancer and published in the New England Journal, and it gave us a lot of hope. But remember, this was a New England Journal paper on 38 patients, right? And so the mutation, the KRAS G12C, is in 2% of the PDACs, right? So this is a very niche subset. The pan-KRAS inhibitor, and I know you guys have this trial open here as well, for all comers of GI tumors, will be very interesting to see. It's in the metastatic setting. It's a much, much bigger trial, and it will hopefully give us a little bit more insight. The KRAS inhibitors have a very finite time of working, right? So this is not a cure. It is something that helps you move that to the right. And then, of course, Dr. DeLillo knows this from his time at Hopkins, some of the vaccine trials, and then some of the immunotherapy trials that hopefully will be the next frontier. But it is our understanding of that microenvironment. And Dr. Norton's paper that just came out recently really highlights this again. It is not just the adenocarcinoma cell. It is really the entire microenvironment that we need to attack. I'm not going to spend too much more time on lab stuff, but my lab has spent a lot of time now on a new CAR T, and we're very close to getting our IND to be able to run this clinical trial and hopefully get some CIRM funding. So it's great to be in California and have that as an option. So the last part of this is, for those of you on your academic trajectory, you have the great benefit for being at a phenomenal university. Being at Stanford is an incredible environment. Look outside of your department. Look outside of the School of Medicine. And so for those of you who are interested in value-based healthcare, Michael Porter actually gives a free course the first week of January before all the HBS students come back in. And it's a very intense course, and it's phenomenal. Tom Seeley was his sort of co-director, and he was chief of cardiac anesthesia here at Stanford for a long time before he went to MD Anderson. And so I took this course, and it was really transformative because they teach you a lot about time-dependent based account costing. And it made us relook at our pancreas program and the resources that we really needed and the areas of true waste. And it really helped us realign that. The other reason it was really important is that it gave me a very different insight into some of the finances of medicine. And when I was walking back from HBS back to MGH, my former fellow, Marcela Del Carmen, so she was the fellow on Gyn-Onc when I was an intern, and she had just been named the MGPO CMO. And so I called her to congratulate her, and she said, if you're studying all this stuff, do you want to take my seat on the executive council? And that was incredibly helpful because that was then the path to be elected to the MGPO Board of Trustees. And that gave me a whole new insight as to how the institution is run and some of the drivers. You need to remember that the members of your board are all volunteers. They are all very smart, but none of them are in medicine. And so they're very eager to talk to you and learn from you and help you understand some of the pressures. And these are some of the 4 people that have remained enormous mentors. And Nitin Noria, who is the former dean of HBS, spent a lot of time with me when I had gotten my new position as the head of the Office of Clinical Careers. So again, looking outside of your department and looking for what the institution needs. And you say, okay, this gives me an opportunity to help the promotion process of people in medicine, pathology, neurology, and allowed me to meet with all of the chairs of all of the departments so that we could realign our academic assessment and help people advance in this somewhat arduous promotion process. I don't think anybody has an easy promotion process, right? It's a lot of paperwork and it's pretty arduous. And so this was now 2022, and I had a really robust clinical practice. The lab was going. We had our clinical trials. And the question was really, is there a point in your career that you think about pivoting, that you think about changing? And there is a lot to take into consideration. I'm married to a surgeon who was the chief of spine, right? Who had a really big spine tumor practice. And it's really your friends, is your friends who have some similar challenges and that you need to really talk through these types of decisions, because they give you an enormous amount of insight into some of the things that you need to consider. For us, it was an opportunity. As some of you heard at dinner last night, my husband is an orthopedic oncologist and a spine surgeon. He was the chief of spine in a big spine tumor practice, but he was operating 3-4 days a week. And during COVID, turns out the orthopedic surgeons weren't that much help in the ICU, but they were really good at giving vaccines. So he gave a lot of vaccines when the vaccines came out. But he had a very different COVID experience than the people who do general surgery, right? Like, we were in the ICU, we were putting in lines, we were taking care of these patients. And he decided to pivot and do a master's in data science. And because everything moved online, he actually did it at Berkeley. So while that seems like a great idea, it turns out that it is a boatload of work, especially when you're 50 years old and you're doing 40 hours of homework a week and all that. But it really transformed his research, right? And he said, I really want to try to get this research to the next level. And so when we were thinking about this potential transition, that came into play. Because it would give him an opportunity to be able to pivot and not be operating 4 days a week, but to be operating less. It was also a time point before our oldest would have gone to high school. So when we moved, our oldest started 9th grade. And for us, that was really important because we didn't want a kid to have to move in high school. I felt like it was too much pressure. And so I felt really fortunate to have been recruited by the leadership team. Bruce Gewirtz was the former chair and is still around. And I have to say, he has been a phenomenal mentor. There are very few people who first of all, decide themselves to step down from their position, but then actively help the person who takes their job. And he's really been tremendous. Tom Krisolak was the CEO, and including me, everyone was a little bit nervous as to who's going to come next. And we've seen around the country when there are leadership changes at the top, some people's jobs disappear. And so I'm actually very, very fortunate because Peter Slavin, who was the head of the MGH for 19 years, and I got to work with on the executive council and on the board, is now the new CEO at Cedars. So that has been incredibly helpful in terms of my progression at the institution. I'm very lucky for the division directors that are in the department, really a phenomenal group of people who many of you know, and a fantastic faculty. And it's been a lot of fun to be able to pivot, not thinking only about my research career and what I want to do in terms of trials and things like that, but to really pivot to how can you help the people in the department get what they need so that they can do what they are passionate about. A lot of people say, well, what do you want me to do? I'm like, I don't want you to do anything. I want you to do what you're passionate about, because all of this is a lot of hard work, as you all very well know. A lot of this is done on your nights and weekends. And so you need to be passionate about it, because at the end of the week, we all only have 168 hours, and you want to be able to feel like you've used it well and that you feel fulfilled by your career. So it is a true honor to be here in the name of my mentor. I would not have gone into surgery without Dr. Norton's mentorship and leadership. And he's really been a mentor throughout my career, not only from all of the papers that I've read that he's written, and all the changes that he's made in the field, but also just him as a person who's an incredible family person and a mentor to so many residents, students, and now faculty around the country. A very big thank you to my senior resident, Janie Pratt. Janie Pratt was a PGY5 when I was an intern. So that's how long I've known Janie, since 1997. And, having Tiffany and Nora here, who are both residents at MGH, it's just, the residents and the students and fellows really bring so much joy and so much energy to every part of the job. And then, of course, to our patients who entrust us to take care of them, as well as our family and friends who are the ones who, at the end of the day, keep us going. So I thank you so much for being here, and I'm happy to take any questions. It's a real honor to be here, so thank you.